Okay, so today, of course, is Accurate Accreditation Surveyor webinar. We have Marie here with us, who will be conducting this. She is a surveyor herself. So we'll go ahead and get started. Marie, are you there?
I am. Good afternoon, and thank you for having me.
You're very welcome.
Next slide. We're going to review the updated guidance for ASC's Appendix L of the State Operation Manual, which came into effect in June 17th of 2022. We're also going to identify some hand hygiene guidelines by AORN and janitorial cleaning review, just for some points to look at your janitorial cleaning process and policies within your center, and some fun things to do with gloves. Next slide. The first, that we're not looking at all of them. We're going to send you the Operation L guidelines that identify the changes. We're going to review a few that we thought were very pertinent for you. The first one is Appendix LQ2 4.16.2 and the definitions, which speaks to the fact that an ambulatory surgery center or an ASC means any distinct entity that operates exclusively for the purpose of providing surgical services to patients and not requiring hospitalization, and in which the expected duration of services would not exceed 24 hours following an admission. The entity must have an agreement with CMS to participate in Medicare as an ASC and must meet the conditions set forth in subpart B and C. The interpretive guidelines are that minor clarifications were added to this guidance for space sharing and recovery centers. A distinct entity, the physical or temporal separation. CMS's longstanding interpretation of the distinct entity requirement is that the ASC must be physically and administratively distinct from any other entity. The life safety code implication for sharing space, if the ASC is located in a building that is shared with other entities, is that the ASC must physically be separated from the other tenants by walls with at least a 1 hour fire resistant rating in accordance with the National Fire Protection Association. The fact that an ASC is permitted to use the same space as other entities at different times does not mean that the ASC is relieved of its obligation to comply with the physical separation, fire alarm, and other applicable requirements of the NFPA at life safety standards adopted for ASCs in accordance with this 416.44B. Next slide. The ASC must have an effective procedure for the immediate transfer to a hospital of patients requiring emergency medical care beyond the capabilities of the ASC. This hospital must be a local Medicare participating hospital or a local non-participating hospital that meets the requirements for payment for emergency services under 48.2.2 of this chapter. The ASC must periodically provide the local hospital with a written notice of its operations and patient population served. New periodic written notice requirements, added guidance regarding the written notice of the local hospital about the ASC's operations and patient population served. Next slide. The ASC is required to periodically provide the local hospital, as specified in 4.416.41B3, with written notice of its operations and patient population served. Communication between the ASC and the local hospital is important to assure that hospitals are aware of the potential for receiving patient transfers from the ASC. This was effective September 30th of 2019. CMS recommends that the written notice be provided upon opening of the ASC and at least every 24 months to ensure the ASC keeps the local hospital informed and up to date on ASC information and any pertinent patient population changes. The written notice must include information concerning the ASC's operations, the patient population served by the ASC. The written notice may be provided to the local hospital electronically or through the mail. The ASC should maintain copies of their notices to demonstrate that they are providing such notices periodically as required by the regulation. While a transfer agreement between the local hospital and ASC is no longer required by regulation, communication between the hospital and the ASC is encouraged. Now, understand that it should also be noted that transfer agreements may be required by the state law for licensure purposes, providing that the local hospital with written notice does not preclude those ASCs and hospitals with functional working relationships to continue to have written transfer agreements previously required by the conditions of coverage. I know for a fact that Michigan in their health code still requires a transfer agreement. Should an ASC have an existing transfer agreement in place with a local hospital, this could meet the requirement for the written notice as long as the agreement contains the required information required the ASC's operations and patient population as noted in the regulations. Even if all of the operating physicians within the ASC have admitting privileges at the local hospital, a written notice is still required per the regulation every 24 months. Next slide. And Appendix L 4.6.42, the standard is the anesthetic risk and evaluation. And this is that immediately before surgery, a physician or anesthetist as defined at 410.69 of this chapter must examine the patient to evaluate the risk of anesthesia. The interpretive guidelines are that anesthetic risk and evaluation guidance to allow a physician or anesthetist to examine the patient to evaluate the risk for anesthesia. Immediately before surgery, a physician anesthetist as defined of this chapter must examine the patient to evaluate the risk for anesthesia. The examination must be specific to each patient, and it is not acceptable for an ASC to assume the coverage of a specific procedure by Medicare or an insurance company as an ASC setting is sufficient basis to conclude that the risk of surgery are acceptable generically for every ASC patient. The requirement for a physician to examine the patient immediately before surgery is not to be confused with the separate requirement 42 CFR 416.52 A1 for a history and physical assessment if required by the ASC policy. If an ASC's policy requires an H&P be conducted prior to the surgery, review of the H&P is considered to be a component of a pre-surgical assessment as required under 42 CFR 416.52 A2 upon admission. In those cases where a history and physical assessment is required and performed in the ASC on the same day as the surgical procedure, the assessment of the patient's procedure anesthesia risk must be conducted separately from the H&P. See the interpretive guidelines for 416.42 A1-2 and 416.52 A1 and 2. Next page. A physician must examine the patient to evaluate the risk of the procedure to be performed. The interpretive guidelines 416.42 A1-1, the examination be specific to each patient, and it is not acceptable for an ASC to assume, for example, the coverage of specific procedure by Medicare or an insurance company in an ASC setting is sufficient basis to conclude that the risks of the surgery are acceptable generically for every ASC patient. The requirement for a physician to examine the patient immediately before surgery is not to be confused with the separate requirement at 42 CFR 416.521 for a history and physical assessment, if required by the ASC policy. If an ASC policy requires an H&P be conducted prior to surgery, review of the H&P is considered to be a component of a pre-surgical assessment as required under 42 CFR 416.52 A2 upon admission. In those cases, however, where a history and physical assessment is required and performed in the ASC on the same day as a surgical procedure, the assessment of the patient's procedure anesthesia risk must be conducted separately from the H&P. This is always a confusion of how do I write my policy and who sees my patient for anesthesia assessment versus history and physical assessment. Next standard. This Operation L is a little confusing because I'm going down it the same as it does, and this now puts in the physical environment continued, which is 40.44, which puts it after, and the ASC must provide a functional and sanitary environment for the provision of surgical services, and each operating room must be designed and equipped so that the type of surgery conducted can be performed in a manner that protects the lives and assures the physical safety of all individuals in the area. The interpretive guidelines is that the fire and building safety must align with the regulatory changes and adoption of the 2012 edition of the Life Safety Code and the Healthcare Facilities Code. Next slide. Although the term OR includes both traditional sterile ORs and procedure rooms, this does not mean that procedure rooms must meet the same level of design and equipment standards as the traditional operating rooms. Whether performing surgical procedures in a traditional OR or a procedure room, each room must be designed in accordance with the industry standards for the types of surgical procedures being performed in the room. The ASHR standards is referenced by the Facility Guidelines Institute in the 2010 Guidelines for Design and Construction of Healthcare Facilities and has been approved by the American Society for Healthcare Engineering of the American Hospital Association and the American National Standards Institute. And this addendum D, which is the change of the ASHRA standards, requires relative humidity in ORs to be maintained between 20 to 60%. ASCs must consider sterile supply and medical equipment manufacturer instructions for use regarding the required humidity levels prior to any humidity level adjustment. Failure to maintain manufacturer required humidity levels must void sterile packaging and result in medical equipment and malfunction. You need to know in your sterile packaging room what your temperature and humidity is, and that needs to be monitored as well as in the operating room. Procedure room guidelines may be a little bit different than the OR and the sterile packaging. Next slide. Appendix L, Q101 4.16.47, we're talking about the medical records and the requirements for medical records, which have been revised on Appendix for medical records, for the form and content, and for confidentiality in clinical records. The medical records, the clarified language related to medical record systems and confidentiality of medical records, the ASC must comply with all of the standards within the CFC, which is important to note that the ASC CFC do not prescribe the specific details of how the ASC must set up its medical records. However, the ASC staff must maintain complete, comprehensive, and accurate medical records to ensure adequate patient care, and the ASC must comply with all ASC CFCs related to medical records and patient privacy and all other relevant state and federal privacy requirements. The review of the following center's medical record policy is that your policy must include the medical history and physical assessment as applicable if required by the ASC's policy. So your medical history and physical assessment policy can specifically identify what your requirements are in your center, and then you're required to follow them. A pre-surgical assessment, you need to update of the H&P upon admission as applicable if required by the ASC's policy, and assessment of the risk of the procedure and anesthesia. A documentation of properly executed informed consent, finding and techniques of the operation, including complications, allergies, and adverse drug reactions that occurred, orders signed by the physician for all drugs, biologicals administered to the patient, documentation of adverse drug reactions, if any, documentation of the post-surgical assessment of the patient, including the recovery from anesthesia, documentation of reason for the transfer to a hospital, if applicable, discharge notes, including documentation of post-surgical needs, and a discharge order signed by the operating physician. Now, there are some physicians that try to sign all of these forms at the same time, and the timing of them, you're responsible for making sure that the history and physical and the informed consent is completed before the patient goes in, and the anesthesia assessment is completed before the patient goes into the OR. The discharge orders, the immediate note after surgery needs to be signed after the procedure is done. Next slide. Conditions for coverage for infection control. The ASC must maintain an infection control program that seeks to minimize infections and communicable diseases. The infection control, they added clarification related to reporting of infection control breaches that could potentially expose patients to the blood or bodily fluids of another. Some types of infection control breaches, including but not limited to medication, injection practices, and disinfection and sterilization of medical devices and equipment, pose a risk of bloodborne pathogen transmission that may warrant engagement of public health authorities to conduct a risk assessment and, if necessary, to implement the process of patient notification. So your policy needs to state, if you have one of these issues, how you would notify the state and how you would notify the patient. Next slide. The Appendix L416.44D talks about the standard for emergency equipment. The emergency equipment, the ASC's medical staff and governing body must adopt written policies and procedures that address the specific types of emergency equipment that must be available for use in the ASC's operating room. The ASC must conduct periodic assessments of its policies and procedures in order to anticipate the emergency equipment, supplies, and medications that may be needed to address any likely emergencies, taking into consideration the types of patients that ASCs serve and the types of procedures performed in the ASC. This is important as more complex surgical procedures move from the inpatient or hospital outpatient setting to the ASC setting. For example, if cardiac or spine procedures are being performed, what equipment, personnel, and training may be needed to handle specific emergencies associated with those surgical procedures, airway maintenance, emergency equipment specific to cardiology. So basically what they're saying is that your you have to have a policy that identifies all of those supplies that are in your crash cart that are specific to the type of procedures you're doing in your center. And this policy needs to be reviewed on an annual basis with your updated maintenance. Make sure that your American Heart Association algorithms are the most current, which I think are currently 219 or 221. And your M-House posters are updated to the 2019 standards. Next slide. Upon admission, this is Appendix L 416.52A 2 and 3. Upon admission, each patient must have a pre-surgical assessment completed by a physician who will be performing the surgery or another qualified practitioner in accordance with the applicable state health and safety laws, standards of practice, and ASC policy. The interpretive guidelines is upon admission, each patient must have a pre-surgical assessment completed by a physician who will be performing the surgery or other qualified practitioner in accordance with applicable state health and safety laws, standards of practice, and ASC policy. The pre-surgical assessment must include documentation of any allergies to drugs and biologicals. The pre-surgical assessment must be completed upon admission for each patient and is separate from any H&P assessment that may also be required by the ASC policy. The operating room physician or other qualified practitioner in accordance with applicable state health and safety laws, standards of practice, and ASC policy must complete the pre-surgical assessment. The requirement at 416.42A1 for a physician to examine the patient immediately before surgery to evaluate the risk of the procedure for that patient is one component of the requirement. This component must be conducted by a physician immediately prior to surgery. The ASC policy requires an H&P under 416.52A1, and such an H&P is performed on the day of the surgical procedure in the ASC. Some, but not all, elements of the pre-surgical assessment may be incorporated into the H&P. However, the assessment of the patient's risk for the procedure and anesthesia required under 416.42A1 must still be conducted separately. The patient's medical record must include documentation that the patient was examined prior to the commencement of the surgery. The physician or the qualified practitioner uses their clinical judgment based upon their assessment of the patient's condition and comorbidities, if any, in relation to the patient's planned surgery to decide the extent of the assessment needed. The patient assessment and admission added guidance addressing the regulatory change to this history and physical requirement. Next slide. This states that the ASC must develop and maintain a policy that identifies those patients who require an H&P prior to surgery. No specific list of surgical procedures or patient types is specified in the CFCs. Instead, the ASC is expected to determine which patients require an H&P, including the time frame for completion, and develop policies to ensure those patients receive the H&P prior to surgery. Policies that must address certain patient characteristics that may necessitate the need for examination and testing prior to surgery. These factors include, but are not limited to, the patient age, considering the need for H&P based on the pediatric, adult, or generic age differences, diagnosis, the type and number of procedures scheduled to be performed on the same surgery date, known comorbidities, which is cardiac pulmonary disease, the planned anesthesia level, minimal sedation, general sedation, etc. The patient's medical record must include documentation that the patient was examined prior to the commencement of the surgery. The physician or qualified practitioner uses their clinical judgment based on their assessment of the patient's condition, comorbidities, if any, to relation to the patient's planned surgery to decide the extent of the assessment. Your policy can include whether you need a 30-day H&P or not, but you still, the day of procedure, need to have the examination of the patient for the appropriateness for the procedure being performed that day. So you decide, the physician needs to examine the patient. He can use the information for pre-assessment or the pre-admission assessment for identifying no changes, but your policy has to reflect what you're doing. ASC's H&P policy must include the timeframes for the examination to be completed prior to surgery. There is no one-size-fits-all approach to the timeframes for H&P completion. Although no longer required by the regulation, the ASC must not preclude from retaining in ASC policies the previous timeframe requirement that H&Ps must be completed and documented for each ASC patient no more than 30 days prior to the date of surgery. Next slide. This pretty much goes through the same information, which is that the current regulation allows ASCs to self-impose restrictions and allows all affected ASC providers to retain current restrictions for some categories of surgery. It is important to note that the state law may have specific timeframe requirements for ASCs to consider. Policy development must be based on nationally recognized standards of practice and guidelines, as well as any applicable state and local health and safety laws. Consideration should also be given to the information on the history and physical recommendations from specialty societies and medical literature. Patient assessment admission added guidance addresses the regulatory change to the history and physical requirements. So the American College of Surgeons, the American Society of Anesthesiologists, and the American College of Cardiology, the American College of Ophthalmology have best practice guidelines or recommendations for preoperative care. The ASCs are encouraged to review the scope of procedures performed within the ASC, along with the national standards, and then engage the governing body and the medical staff to determine which patients require an H&P prior to surgery. The ASC should conduct periodic assessments of its policies and procedures. It is expected that you review all of your policies on an annual basis for review and approval and revise them according to updated requirements such as these changes in June of 2022. The types and procedures performed in the ASC and the ASC should also consider their policy and process for cases where the patient is referred to the ASC for surgery on the same day. Those policies have to require your H&P for same day surgery. Next slide. This speaks to the disaster emergency preparedness plan that you are to have in place. And in 2015, CMS came out with a guideline for what your emergency disaster preparedness plan had to have in it. This is an update to state that the cross-reference added to Appendix Z for the ASC emergency preparedness, you need to refer to Appendix Z for the condition of coverage, the emergency preparedness in the interpretive guidelines for 416.54. ASCs must comply with the applicable emergency preparedness requirements referenced in Appendix Z of the State Operations Manual. Refer to Appendix Z for all applicable requirements and guidance for emergency preparedness. Compliance with the emergency preparedness requirements is assessed in conjunction with either the ASC Health Safety or Life Safety Code survey in accordance with the survey protocol outlined with Appendix Z. The other technical corrections, the regulatory numbering and acronyms align with the CMS regional office change to CMS location. Remember, there needs to be communication with your county's emergency management system as to your assets in the center and your willingness to participate in the community disaster. And you need to have proof of that communication to go along with your hazard vulnerability assessment and your disaster emergency preparedness plan. Next slide. That ends the review of your Operations L changes that we identified that we were going to look at. When you look at your Operations L and you go through it, the red is all of the changes that were identified in June of 2022. We reviewed some of them. We could not go through all of them. What we're going to review now is an updated guideline for hand hygiene and a fun way to ensure that your staff is compliant with hand washing. And also we're going to review your janitorial guidelines for what you need in policies and procedures and how you might identify whether your janitorial service is in compliance for what you want. Effective hand hygiene, the updated guidelines by AORN identified 5 areas, and they want you to ditch all nail lacquer for the scrub roll. It is well known that nail polish can harbor transmissible bacteria, but with so many kinds of nail polishes on the market, they wanted to clarify terms. We focused on the cosmetology literature to add terminology updates to those new recommendations. All nail polish is now referred to as nail lacquer, for better described as dissolved resins applied and dried to form a hard glossy coat. The enhanced nail lacquers such as UV, shellac, dip nails, and nails fixed with adhesive or are differentiated. When performing the scrub roll, both nail lacquer and enhanced nail lacquer should not be worn. Non-scrub personnel who are permitted to wear lacquered nails should ensure their nails lacquer is free of chips and cracks. Now, I don't know how many of you realize that when WHO did their update of hand hygiene guidelines in 2008, they stated that anyone using nail lacquer or nail polish should change it every 4 days. Many of our people don't, and there are problems with it growing out and leaving a ridge behind, which causes an issue. Reduce the spread of waterborne pathogens at hand hygiene stations. In accordance with 2017 CMS mandate, healthcare facilities are now required to establish a water management program based on evidence showing gram-negative pathogens that often cause SSIs that are present in faucet hardware and sink drains, including hand hygiene sinks. Facilities need to develop a safe water pathogen plan that recognizes and reduces bacterial contamination in pre-op sinks, faucets, and drains. This is from the article from the AORN. She says to start with these key actions: determine whether electronic faucets will be used in the perioperative setting and under which circumstances, considering risk factors such as sink utilization, water flow rate, complexity, and composition of internal components. Reduce splashing or dispersion of water with known solutions, such as using deep sink basins, faucets that don't discharge directly above the drain, and adjusting water pressure. Make surgical hand rubs and scrubs accessible. Surgical hand antisepsis can be completed by performing a surgical hand rub or a surgical hand scrub based on new supporting evidence, DK explains. The guidelines suggest hand rub and alcohol-based hand hygiene dispensers may be placed inside the OR or procedure room following NFP guidelines for fire safety. Along with newly installed hand hygiene dispensers, make sure hand washing stations are still available for soiled hands. Next slide. You need to evaluate hand health with specific hand hygiene products. Based on new research, we found that specific hand hygiene products that identify skin irritation, including transdermal water loss that can cause skin damage, the guidelines suggested perioperative nurses participate in assessing hand health in these ways. Form an interdisciplinary team that may evaluate your hand hygiene products and request information from manufacturers, specifically studies that measure transepidermal water loss. Look to a new table in the updated guidelines that lists the antisepsis irritant potential. And 5 is to get creative to boost hand hygiene compliance. The fast-paced workload in perioperative care can lead some to make hand hygiene less of a priority. That's why new compliance recommendations are included in the guidelines, such as use electronic or paper reminders as part of a quality program to improve hand hygiene. Look at ways to streamline processes and workflow to limit the number of indications for hand hygiene, such as decreasing the number of times gloves must be removed because something was forgotten, by making supplies ready ahead of time. Use video observation of specific behaviors that increase or decrease workspace contamination to identify best practices. And after new hand hygiene practices are developed, use simulation to evaluate new techniques in risk-free settings. The reason they're telling you to look at video, if possible, is because there are many times that we miss what you're observing on a daily basis, and that gives you the ability to look at it more specifically. Next slide. One of the things that we identified is that GlowGerm has a product, and there are other products out there. This one was just one that we identified at Accurate that might be very beneficial and fun to use in hand washing training. This is a process from GlowGerm on how you use it and how you check your staff in their hand hygiene process. Spread over both hands completely as applying hand lotion. Be sure to cover your hands completely, particularly under nails, around cuticles, and between fingers. Wipe off the excess with paper towel and do not let the gel contact clothing, as staining may result. When using white GlowGerm gel, use the same procedure with a pad of gel about the size of a nickel, wiping off excess, usually not necessary. Place the hands under a UV lamp to view the glowing germs that exist before hand washing. Demonstration works best in a darkened room. Then perform the FDA recommended hand wash using soap and warm water. The amount of effort required to remove the simulated germs is equal to that of removing most bacteria. Place the hands under the UV lamp, paying special attention to the thumb areas around the nails and between the fingers. The UV lamp reveals the remaining germs as proof of improper hand washing. If you haven't done this, it really is amazing at how much we miss, because most people think that they wash their hands thoroughly and they do it for maybe 10 seconds, 15 seconds, but they need to do a full 20 to 25-second hand wash and observe how well they're cleaning between their fingers and under their nails. Complete removal of GlowGerm with normal washing is more difficult if skin is chapped or cracked, indicating that bacteria is also harder to remove. This will require a hand care regime with a quality lotion twice daily and a judicious use of hand sanitizing gel. The next slide. When you're looking at your janitorial service or your environmental cleaning, one of the steps that you need to have is that you need to have housekeeping policies, which are written policies that cover all areas of the center. What are the tasks that should be cleaned on a daily basis, a weekly basis, a monthly basis? How frequently do they clean the light switches? How frequently do they clean the doorknobs? Meet with the staff to discuss the problem areas in the center to ensure that these areas are cleaned. Keep housekeeping checklists for all areas and review the recommended practices from AORN, from CMS, from CDC for hand or for janitorial services. Terminal cleaning of the ORs. Are you aware of all of the guidelines that need to be done for the terminal cleaning within your center, and does your policy meet those? Your expected schedule for all of those areas. Again, your light switches, your doorknobs, your floors, your walls, your vents, all of those areas, and the contents of the different rooms. Who's responsible? Is your staff responsible for doing the tops of the machines and the tops of areas, or is the environmental cleaning people responsible for that? Document your housekeeping staff's education for confidentiality, infection control, and any language barriers. You're responsible to make sure that your housekeeping staff have the understanding of their responsibility for HIPAA, for confidentiality, for your infection control, for their immunizations. They're not with any of the patients, but they still are responsible for a certain education in infection control. Identify your ASC quality and infection control specialties that you are performing, ortho, eyes, etc., and the requirements for the cleaning that needs to be done to ensure that all of those are met on a daily basis by your staff and your staff's education for cleaning, as well as your environmental services staff. One of the questions that your infection control policy needs to identify is what education do they get, and is it the same or different than your own? Next slide. Many centers don't think about using glow germ for identifying surface cleaning and for floor cleaning. But if you get some and you lightly dust a small amount of glow germ powder over an entire surface area, and you clean that surface until all visible powder disappears, you pass the UV lamp over the surface and the remaining traces of powder will glow on the areas that weren't washed thoroughly. When checking restroom areas for cleanliness, UV lamp may be used for the detection of urine without using glow germ powder. Interestingly enough, a lot of times if you just do a small spot on a counter, on a handle, door handle, on a light switch, or underneath your operating table to make sure that they're cleaning consistently, and you only need to do it maybe once a month or in a different area at different times, but you're able to track whether your cleaning people are doing what they need to do appropriately. For food cross-contamination, you want to make sure that you're, and we don't do any of this, I didn't look at this whole thing, but you might want to even do it on your areas. If you perform any type of where you allow your staff to have their food, you have to identify a clean and a dirty area in your center that is non-patient care, that your staff can have their drinks, because you can, it's still, you shouldn't have any food or food products at the nurse's station or in a patient care area. We're ready for any questions that might be. I know that was a lot of information and some of it's confusing, but I hope that I can clarify it for you.
Yes, Marie. It looks like we've had a couple questions rolling in here. I'm going to start with Robin Carey asked, are surgeons required to have hospital privileges in California?
I'm going to have to look that up. I don't think that they have to have hospital privileges if you have a transfer agreement. And
Okay,
that has always been, if you have a transfer agreement with a hospital, the physicians don't have to have privileges at the hospital. Because many physicians don't have hospital privileges anymore because they have hospitalists and that stuff. But if you're sending to the emergency room, that's the requirement for that agreement with the hospital, or at least the communication with the hospital of the type of patients that you have and what they might get from you.
Okay, and Robin, you can shoot me an email and I can get Marie to clarify more as she looks a little bit further into that. The next question here is from Jennifer Vasquez. She says, can the governing board approve a CRNA to provide anesthesia services without the supervision of a physician? Does the ASC have to list supervision of CRNA on each physician's delineation of privileges that utilize the CRNA?
Your delineation of privileges, if your state does not allow the CRNA to practice independently without supervision of a physician, then every delineation of privilege that has a surgeon that is utilizing the CRNA has to have that request for privileges. And you have to have a policy that has been established that identifies the responsibility of the supervising physician in your policy. So yes, if your state doesn't allow the CRNA to practice independently, every surgeon that is using that CRNA for anesthesia has to request privileges for supervision of the CRNA.
Okay, and the next question is from, I hope I'm saying this right, Shailene Chavez. How do most centers document this anesthetic risk and eval? Our MDs complete same day HPs, but since it must be separate, can a simple statement on the nurse pre-op documentation suffice? Or does this need to be a completely separate document?
It can be on the pre-assessment if the physician, one of the things that I state that if you have an anesthesiologist that is doing anesthesia, then anesthesia will do the pre-assessment and the plan for anesthesia and the ASA. If your procedures are being done by a physician and he's using a local or he's overseeing conscious sedation, his responsibility is for the anesthesia plan and assessment and ASA as well. So there needs to be documentation that the physician examined the patient for anesthesia. The plan of anesthesia is local / conscious sedation, and the ASA is 1 or 2. So
Okay. Oh,
it can,
sorry.
it can be on that form, but he has to sign the form. It can be on the pre-admission assessment page, and it can be in a box down at the bottom, but the physician doing the procedure has to sign that he did that pre-assessment and the approval for anesthesia, the plan for anesthesia.
The next question is Jennifer Vasquez. Is an email to your county's emergency management system discussing your assets in the center enough?
Yes, as long as, because many of them don't answer you, but you have to show the email that says that you contacted your emergency management system or your local fire department for the emergency disaster preparedness in the community. And that what your patient population is, how many rooms you have, and what your assets are. Like, what are you able to, like, if you needed to triage people, how many rooms do you have? What are you available in case they needed assistance?
Okay, another question here. Does the surgeon and the CRNA need to assess the patient in pre-op?
The surgeon needs to examine the patient and mark the patient for procedure. The CRNA needs to see the patient in pre-op for assessment for anesthesia and for the informed consent for anesthesia. So yes, and you can decide, does the physician listen to heart and lungs, or does the CRNA listen to heart and lungs? But somebody should listen to heart and lungs.
Okay,
But they
and
both,
oh, sorry, go
but they
ahead.
both have to see the patient in the pre-op area.
Okay, I see another question here. Do you need to notify the local hospital of the providers in the ASC in the notification?
No, because your responsibility is patient population, procedures performed, and the so they know what they might receive from your center. So age, it should be age. If it's peds and adults, what types of surgeries are you doing or procedures are you doing? It doesn't have to list the physicians.
Okay. Does anybody else have any questions? You guys can type those questions out there in the Zoom chat. We have a few more minutes left here with Marie. So any questions covering any of the information we've gone over today, now's a great time to ask those questions. So I'll give you guys a couple more minutes to get those put in to the chat before we close out this webinar. So one more question here. Does an ASA level need to be documented on a local patient? And does heart and lungs need to be listened to on locals if not seeing CRNA?
Your history and physical policy needs to state that. For locals, I do not believe that they need to have, I personally do not believe that they need to have heart and lungs, but remember that you would identify in your history and physical policy for those patients that are having locals. It would just be the physician marking the area and assessing the patient appropriate for today. But if there's no CRNA, that your history and physical policy should state from your governing board what you believe needs to be done.
All right. Do you guys have any other questions regarding anything that we covered today? Keep in mind, oh, go ahead, Marie.
I forgot, I didn't say whether they needed to put ASA in. What they need to put in is that the patient was assessed, that the plan of anesthesia is for local, and usually those patients are 1, 2, or 3, and it's not hard for the physician to figure that out according to the standards. So he should put an ASA in.
Okay, perfect. So any other questions? You guys go ahead and get those in the chat here. We'll do another minute. I will email this PowerPoint out to everyone, as well as the recording. Well, the recording I'm not going to email out. The recording will be placed in Accurate Accreditation's website in the Help Center. So if you click on your name in the top right corner when you're logged into Accurate Accreditation, you have the Help Center, which pulls up the chat bubble. And there is a spot there, it says see more categories. And if you go to educational webinars, that's actually where we store these recordings. So you'll see 2 of them that we did last year, 2 or 3 from last year. And then probably by tomorrow or the next day, you'll see this one in there as well. So if you want to share it with your staff or revert back to it, that recording will be there. But I will email out the PowerPoint slides for everybody. Okay, Marie, I'm not seeing any other questions come through. You guys have my email address. If anybody has questions that you think of later, just shoot me an email. I'll pass it on to Marie and she will get those answered for you. But I want to thank everybody for joining today. I hope this was helpful. Marie, thank you as always.
Well,
This was
thank you, Marissa, and all the participants. I hope that everything was as clear as it could be. It's difficult with CMS to understand sometimes. I appreciate you and I thank you very much.
awesome. Thank you so much. You guys have a great day.